Welcome to the New England Journal of Medicine at the annual meeting of the European Society for Medical Oncology. I'm Stephen Morrissey, managing editor, and I'm talking with Eric Rubin, editor-in-chief, and Oladapo Yeku, associate editor of NEJM Evidence. We're looking at the Ambassador study, Adjuvant Pembrolizumab versus observation in muscle-invasive urothelial carcinoma. Yeku, what is the current standard of care for patients with high-risk muscle-invasive urothelial carcinoma after they've undergone surgical resection?
This is individualized based on if the patient received neoadjuvant chemotherapy, declined chemotherapy, or was ineligible, in which case a platinum-based chemotherapy combination is offered. For other patients, adjuvant nivolumab is the standard of care based on the Checkmate 274 study published in the journal.
And Eric, what did the investigators ask in this study, and what did they find?
Steve, the study was designed to ask if immunotherapy could decrease the risk of relapse and increase survival after resection. The investigators randomized a total of about 700 patients to either receive pembrolizumab for a year following surgery or to simple observation. There were two co-primary endpoints, disease-free survival and overall survival, with a positive result defined as an improvement in either endpoint. Median disease-free survival increased from just over 14 months in the observation group to almost 30 months in those who received pembrolizumab, a significant difference. Overall survival was similar in both arms, though the number of events has not reached the pre-specified final analysis endpoint. Treatment with pembrolizumab resulted in more adverse events of the type that are generally seen with this drug.
Yeku, is there anything notable in this study about the predictive value of PD-L1 expression or the duration of maintenance therapy?
Similar to the Checkmate 274 study, benefit was seen regardless of PD-L1 expression, even though the magnitude of benefit was different. PD-L1 is a dynamic marker, and there's still much to understand about this particular biomarker. In addition, many contemporary studies utilize up to 2 years of maintenance immunotherapy, and this study adds to the growing body of evidence that perhaps 1 year maintenance might be enough in specific cases.
Yeku, this study has the same issue that many of our studies do, particularly in oncology. Patients who fail, of course, have to cross over to some other treatment, oftentimes the same treatment that was given in the experimental group. So how do you deal with that?
Eric, this is an important point. The authors will eventually have to analyze both groups separately. There is a biological difference between treatment given as maintenance and treatment given for progression, which is where the patients who are crossing over will be in. Regardless, there's a likelihood that this crossover will affect the analysis of the overall survival for this study. In studies where the investigational agent, such as pembrolizumab, has demonstrated single-agent activity, the time to progression in both arms and the effectiveness of further subsequent therapy will be very important to tease out.
Thank you, Yeku. Thank you, Eric. The report of this study is now available at nejm.org.